My watch says it's 10:31. I'd like to welcome you to the Trauma Systems Committee in case any of you don't know exactly where you're at. I'm going to ask individuals to introduce themselves. We do have new members, so we're going to start at the top. Lori, stand up and introduce yourself.
My name is Lori Boyette. I'm the Trauma Program Manager from Hillcrest Baptist Medical Center in Waco, Texas. We're a Level 2 Trauma Center.
David Reeves is not with us. I think most of you know David. David is involved in the RAC in Houston. He's also the Vice Chair of the TTAF organization, and he's been on this committee for 2 terms. The next individual is Ruben Lopez.
Ruben Lopez, I'm the Trauma Director for Valley Baptist in Harlingen, Texas, of course.
Ms. Price.
Can we stand up? I'm Lisa Price. I am the Director of Trauma Services and Emergency Preparedness at Detroit Hospital in Victoria.
Mary Frost is unable to be with us today. Mary Frost is from Houston Children's. They are a Level 1 Trauma Center, and she's also a member of the Registry Workgroup Solution. Alex.
Alex Ramos, Trauma Operations Manager at UMC El Paso Level 1 Trauma Center, Subcommittee Trauma Hospital Chair at Border RAC.
Carla.
Hi, Carla Hosek. I am the Trauma Nurse Director at St. David's in Round Rock. We're a Level 2 Trauma Center.
Hi, I'm Janine Rawlings. I am the Division Manager for the One Call Transfer Center for St. David's Healthcare System.
Okay. Christy.
I'm Christy Reeves. I'm the Trauma Program Manager at Clear Lake Regional Medical Center in Webster, Texas. It's south of Houston, and we're in active pursuit of a Level 3 trauma designation.
Welcome. Dr. Smith.
I'm David Smith. I'm from Texas Health, Harris Methodist. Too much to say, I think. It's a Level 2 Trauma Center in Fort Worth, and I'm the Trauma Medical Director.
The next individual is Craig Ryan. Craig Ryan is the trauma surgeon. He is currently the Chief Medical Officer at Covenant Medical Center in Lubbock. He's been on the committee for 2 terms. Unfortunately, because of other commitments, he couldn't be here today as well. The other individual is, or the next individual, stuck in traffic. He will be here shortly. His name is Ronald Stewart. He's the previous chair of this particular committee. He is also our direct link and liaison to GTAC. He's also a past chair of the American College of Surgeons Region 6. So he brings a plethora of information to us. Kathy?
Hi, I'm Kathy Rogers. I'm the Trauma Program Manager at Christus St. Elizabeth in Beaumont, Texas, and we are a Level 3.
And I'm Lori Vincent. I'm the Director of the Trauma Service at Children's Medical Center in Dallas, and we're a Level 1 Trauma Center.
Okay, Ms. Jane, you can switch us. So the expectations of this committee for those people up here, the committee members are to represent stakeholders. So the stakeholders that you represent are the people in the audience. For those of you who introduce yourself as Level 3, Level 2, Level 1, the expectation is that you'll communicate with those individuals and bring their needs to this facility, as well as the EMS. So we're going to ask Janine to help us with the EMS side of it, and David Reeves brings the RAC side of it to this group. So the next issue is define system needs and improvements. Develop strategies to promote system development. We're constantly trying to improve our trauma system in Texas. Most important thing we're trying to do is improve the outcomes of our trauma patients and provide recommendations for rules to GTAC. So a lot of people don't understand when they first get involved. We're an advisory group, so we're part of the advisory group. So we work with Jane and her group to make recommendations. Those recommendations then go to GTAC, and then from GTAC to DISH. So just because we say this is what we'd like to see does not mean it always comes to fruition. Any questions on that? Okay, Jane. So the rule revision, so Jane, I'm going to let Jane talk about this.
My on and off switch is to just pull the head off of this microphone. Okay. The process where we are right now is that for those of you that have not been aware of it, about a year and a half ago, the committees got together and we asked them to make suggestions back to the department on what they would like to see changed in the entire chapter of 157. So that was all sections. Prior to this, we had looked at reviewing and revising section by section within the chapter. That became very problematic because a lot of these sections are interdependent on one another. So we're tackling the entire chapter at a time. My staff at the time told me I needed my head examined, and I've kind of tend to agree with them at this point, but we're trudging forward. All of the committees over about a 6-month period met and through a vetting process fed suggestions back to the department on every single section of the rule. There were nothing was off limits, nothing was barred. You could make suggestions on any section of the rule. So we took those suggestions and we're still working through them, and we are still incorporating some of those things into rule language and making those changes that the department feels like we can. That process has been, I would say, slow, because there's like 3 of us at the department that are actually doing this. So Emily Parsons is one of them, I am the other one, and Maxie Bishop was the 3rd. Some of you may have heard Mr. Bishop decided to go work for TDM. So Maxie is not going to be with us and past the 15th of this month. So that's going to kind of slow us down a little bit more, and then legislative session hit. So I don't know when we will have a good draft. The intent is to take all of the suggestions that you've given us, incorporate what we feel we can into the rule, get a good draft. And when I say that, I mean it's been through our legal people, that they have looked at it and said that we've not violated any other statute or law. And then that draft, we will come together in a joint meeting of all the committees, and we're going to go over it. And so you'll see what suggestions we took, if we, where they ended up in the rules, how it looks, what we did. And so it would be, I would expect 2 days worth of, probably take 2 days to do that. Wouldn't you think, Jory? Okay. So that's kind of where we are now. The ball is in our court to get the draft done. The rules do not go down our path internally until it comes back through GTAC. So just because y'all aren't seeing them or hearing them or having access to look at them right now doesn't mean you won't see them again. We'll have our joint meeting first, and then they'll go back through committee into GTAC. I know people think that since nothing is being said about them, or they're not hearing something about them, or they're not seeing them, that somehow they're going to miss it. You won't miss it. Okay. So we were hoping to have a good draft done by the summer. I do not know if that will happen or not. It kind of depends on what priorities come our way with legislative session and what we have to do between now and the end of May. So, what questions do you have for me?
There's a lot of questions from people who weren't part of this group.
Okay.
Where can they get the rules that currently exist and those that are proposed? So I directed most people that have sent me those questions to the website. and so you can review the current rules, and then the recommended rules are, where would you give them? They're posted there too, aren't they?
No, they are not. The document that we are working on right now is not posted, and it will not be posted until we have a decent draft that we can bring forward to the stakeholders. Okay. So the only thing that they're going to find posted either on our website or in the Secretary of State's website is going to be the current rule as is written in Chapter 157.
So that covers item number 2 and item number 3. Is that correct, Jane?
Yes.
Okay.
1 and 2. 1 and 2.
Well,
1 and 2.
no, number
Yes.
3 is,
I'm sorry, it's 1 and 2.
sorry, 1 and 2, yeah.
Number 3, Lori or Mary, do you want to talk about this?
Sure.
So at the Pediatric Committee, which met yesterday, there was a position on radiology studies in children, and I'll try to remember the recommendations, but one was that you have dosing specific for pediatrics that would be different from adults, so a specific protocol related to pediatric dosing when you're doing radiology studies. That we limit the radiology studies, the CTs, things like that, that cause exposure, limit those in the pediatric patient, especially if your plan is to transfer. And if you do plan to transfer, ensure that you send the studies as well as the radiology overreads with the patient so that we decrease the likelihood of having to repeat any of those studies. And then limiting, looking at the difference between plain films versus CTs and things like that in children and adult management. So that was the majority of the position statement from the Pediatric Committee that they discussed.
Does anybody from this group have any action from that? Do we want to approve this position statement?
Yes. Approve it.
Motion?
Motion to approve it.
Second.
Second.
Any discussion? If not, those in favor, please say aye.
Aye.
Those opposed, please say aye. I guess before we do that, we should have asked if there was any comments from the audience. We'll come back to you, unfortunately. Okay, so you can go to the next slide, Jane. We already kind of covered that. So I'm going to skip around a little bit. The survey thing is, I think, at the end of the presentation. So the registry, how many of you were at the meeting yesterday at the rec chairs? Okay, so let me just give everybody a short synopsis of what's been going on. So our registry, Tammy, can you stand up? Our state registry has been going through a transition. That transition has been going on for, I guess, a year and a half. So people are beginning to enter data using the hospital data and the EMS data, and so we kind of are in a crossroads of being able to move forward with some issues. So at the last meeting, we asked Jane if we could, off of this committee, create a registry work group. And the purpose of that registry work group is to serve many issues, but one is a communication and a liaison to reach out so that the stakeholders have an input to what's going on. So if you'll look at the slide, the purpose, again, is to serve as a liaison to the GTAC committee. So each committee was asked to identify a member to be on this registry work group. In addition to that, we want to open all communication lines and foster participation from the stakeholders. We want to identify the barriers to the registry, what makes it not work, develop solutions to improve the participation, and develop strategies to improve data quality. And the last issue is to drive change in the trauma system. So we want meaningful data. So the question is, how do we work together to address that? So Jane, if you could just, poor Jane. So again, this is the stakeholders that we have identified. The stakeholders from all of the GTAC committees. So if you're out there and you're wondering, you know, if you're a chair of a committee and you don't know who your person is or you didn't identify one, please let us know within the next 10 days. In addition to that, the RAC Chairs has a representative, that's Kelly Stoll from Scott and White. And then the TTCF, the Texas Trauma Coordinators Forum, has a representative. TTAF has the opportunity to have a representative. The Texas Ambulance Association, the American College of Surgeons, Region 6, and the Texas Association of the Emergency Physicians. Those are the individuals that have an opportunity. Now, what we would like is, just like in this meeting, is anybody can come. It's an open forum. All voices are heard. So the bottom line is we really want to increase your participation. Next slide, Jay. So today we met from 8 o'clock to 9 o'clock, and these were the action items that we defined for anybody that was there, your stakeholder representative. The goal is to define the top 5 issues to address, the top 5 reports that you would like to see for your committee or your stakeholders. Define patient categories. Now, in the trauma centers, we talk about patients by ISS score, blunt versus penetrating, by their age, whether they were scene responses or transfer. So that's what I mean by patient categories. So we're fairly comfortable with that from the trauma centers, but not so comfortable with patient categories from the EMS side. So like some of the questions we raised, is there a difference between those that you arrive on scene and you transport, those you arrive on scene, call a helicopter? How would you like to see the patient categories broken down for EMS? And then the educational needs. The data is only as good as the quality of the data that goes into the registry. So we can't make good decisions with bad data. We come back to the drawing board. So how do we make sure that the people who are entering the data have access to the right courses to be educated on what they need? And then the last is the resources. What needs to change to make this an optimal registry for our state? Next slide, Jane. So I'm going to hold off on this and just ask, is there anybody have any questions on the purpose of the Trauma Registry Work Group? Anybody from the committee have any thoughts, comments? Anybody from the audience? Anybody at the meeting today at 8 o'clock that's out there? Anybody? So did you feel like we were addressing the issues, or at least have a plan to address the issues?
Scott Christopher from Nacogdoches Memorial, TCF, I guess. Question for the registry group. I know that the rehab people are being asked to either submit data now or in the very near future. Should we not invite a rehab person or a group to this work group?
Sure. Good suggestion.
And LTACs, right?
What?
Aren't the LTACs also asked to do that?
Tammy, do you want to just address the issues for the rehab and LTACs?
Yes, we have LTACs and rehabs reporting only for TBI and SCI, and the criteria of those patients is even further specified, that it is 30 days after their discharge for their initial injury that caused the TBI or the SCI. So 30 days after that discharge from acute care. So those are the only patients we're asking to have reported to us. And so we did have a webinar yesterday morning where we discussed some issues that had been brought forward with that, and I think that everybody got their questions answered about what we're doing. Basically, we are ready to start accepting data. So March 1st is the day that we are set to have all of those questions and everything open in production for anybody to be able to report. So that means if you're long-term acute care or rehab that is going to report, that you get a patient into your facility that meets that definition on March 1st, that they got discharged within the last 30 days. So let's say that patient is discharged from your long-term acute care on the 15th of that same month, so 15th of March. You have 90 days from that to report that person. So even though the questions and the access to those questions is in production starting on March 1st, still have 3 months to get those patients reported to us. Some of those accounts were already set up last summer when we had contractors contacting all licensed facilities. Account managers were established for those accounts. So if you are a licensed hospital that has acute care, you already have a trauma account, there's a separate account that's being set up for the long-term acute care and or rehab. And so those records are separate records from the acute record. Those are some of the issues that were discussed yesterday. Some of the folks, if we didn't have a contact for an entity already as an account manager, then sometimes the administrative offices were responding to that, and evidently they had indicated that some of the trauma registrars should report those patients. So that was also one of the things that was discussed was resources and education for that. One of the points that was misunderstood was about the FIM scores, and those are a element that's in there, and if your entity is capturing that data, then we want that to be reported. But if you are at an LTAC, for instance, and you don't use the FIM, then you don't answer those questions. So it's, whether or not you're currently doing that, so we're not saying that you need to get somebody on your staff and get them trained and then you have to answer those FIM questions. No, only if your system is already using those. The other question was about the timeline. So March 1st, you've got 90 days to get those in. The question was, well, what if we don't still meet the 90 days? What if we're still not ready to report? And of course, we were going to work with anybody on that. This is a new reporting initiative. So as people contact us and discuss what their situation is, we will work with them to come up with a solution that fits their situation. We had some questions about which facilities have we contacted already about reporting, and we did start out with customers who stakeholders that we already know and have been working with, and so we started out with a list from our regulatory for hospital licensing. That includes general and special hospitals that are licensed, and so that's where we're starting on this endeavor. And it doesn't mean that other rehab facilities that are not operating under a hospital license, for instance, would not be asked to report data. They will be. So this is going to continue to be built up for the people who should be reporting as we go down the road. And basically, we've had this law on the books for a number of years now for TBI and SCI, and we're just trying to move forward with starting to obtain some data on this important population.
Thank you. So I have an issue I want to bring up to the group and to the audience. So many of us went to the TQIP meeting, the Trauma Quality Improvement meeting in Philadelphia. So if you're a part of TQIP, would you just stand up? There's several people that aren't in the room. So in the discussion, many of you know that the American College of Surgeons is rewriting their book. Their book on optimal resources of the injured patient turns into what we follow to be designated, right? So we had asked them to specifically address the registry section to make sure that the registry staff have the opportunity for continuing education and the opportunity, or actually the criteria, that they must meet the certified trauma registrar criteria within 18 months of in-hire. The American College of Surgeons at that meeting basically said they were probably not going to write that into the rules. They felt like that was based on administrative decisions on cost. So if you remember, my question back to you all when y'all asked if 18 months was too long or too fast to require the registrar to go through the AAAM class and the ATS Trauma Registrars class, my question to you would be, how long do you want to have faulty data? How long are you willing to have faulty data? So what I would like to propose is that this group develop a position statement to send to the American College of Surgeons, asking them to put that into the rules, into their book that for the level 1s and for the level 2s. And the Texas criteria, we've already addressed that. And we addressed it, and we also changed the criteria for the registrar for 1 to 500 trauma admissions. That's already in our recommendations to the state. So I just want to bring that up for discussion to see if the group would be interested. Dr. Stewart, I would value your thoughts on that. Dr. Smith, Dr. Lopez, I mean, I think this is a huge issue. As you visit with other trauma programs, you can find that some trauma programs have a registrar that only gets to be a registrar 3 months before their site survey. And that does not allow time for the appropriate level of education and training. So this is a huge issue, and I think if our state is going to get into a situation where we have good data, quality data, that we can make meaningful use out of, then we're going to have to address the quality of the data that goes into the registry. I'll open it up for discussion.
I think that 18 months is actually overly generous. I think that once somebody's into the program, they need to be qualified as soon as they can, rather than going for a whole year and a half, in my opinion.
And Ms. Klein, I'd be supportive of writing something up and sending it to the college. Is that your question?
Yes.
Yeah.
Anybody in the committee have any thoughts, suggestions, recommendations on that?
I'm definitely supportive of that effort. I think the courses that we're talking about aren't readily available and are costly. And so I think we'd have to figure out a way to make them more accessible.
I would agree with that, what Lori just said. I think that accessibility is an issue. I think within our own systems we can make accommodations for getting them to the course, but course availability is an issue.
Okay. Anybody in the audience want to comment on this? So here's what we really need to narrow down. Do you think the trauma registrar should be required within some time frame to have the certification for a trauma registrar, just like the nurses have to have, you know, TNCC or ATCN, and the physicians have to have ATLS?
Yes.
So everybody agrees on that. So we can work on the time frames and the availability, but I think in the rules we put those courses or similar course or appropriate course or something like that.
So Joy, can I ask, I know I should know, but I'm not certain I know the details. In the Texas rules, do we have the 18-month requirement?
I think it's 2 years.
2 years?
I think we recommended that.
That's what we recommended, was 2 years.
It's still going through the rule process, obviously, but I think the recommendation was 2 years, that the trauma registrar have access for the trauma registrar course and the injury severity scoring class, or I think the terminology says, or equivalent course, and the certification process within 2 years.
So I would just point out, if we're going to write the college, so if we're writing the American College of Surgeons, I would still favor saying 18 months or 2 years. That will increase the availability of courses. If the American College of Surgeons adopts that recommendation, there will be an increase in the number of courses. So we've already required it, or at least we've already recommended it to be required, correct?
Yes.
So from a Texas standpoint, I think that's all positive to recommend the college follow suit.
The only thing I wanted to add is that the Certified Trauma Registry course does require that you have 2 years experience before you can take the course. So when we make that suggestion, we just need to make sure that we include that time frame so that we're not.
And it also requires, is it 8 hours of continuing education a year? Is it 16 hours? I can't remember.
I think it's 8.
So we could provide that, though. I mean, we can find resources. Anybody in the audience have any comments, pros or cons? Mr. Christopher?
I just think we probably don't want to rush them down the fast track too quick, because the individuals that are taking these positions typically need some degree of orientation before they get sent to classes that's total foreign language to them. I mean, it can be super shock, if you will. So the local orientation needs to happen to some degree, and then we'll send them to the class.
So are you saying that you think 2 years is too fast?
I'm thinking 18 months should be the lower watermark, if you will, and 18 months to 2 years.
So I think 18, as she points out, I guess logically thinking about this, the 18 months applies to access to the course, and 2 years refers to the certification. Because you can't, like she said, you have to have 2 years of experience to sit for the exam. Ms. Putz, did you have a comment?
Just one. I'd like to add that taking any of those courses prior to having enough experience using the registry and getting a basic understanding of the whole system and what they're supposed to be doing is futile. They go through these classes occasionally, and then they come out more confused than when they started. So they need a little time to learn their job. Additionally, TTAF started a course that was well received, which is a more basic data management course that they can take early on to get some orientation to the whole process to improve their skills and their knowledge. Just to start.
So let me ask you this. Should we say but by the time they have their survey, they should have that? So if you have one survey by the next 3 years, you should have those certifications?
But the same person may not be in the position. So it's going to be right.
So just leave it.
Talking through all levels, for level 4s as well. That's going to be a struggle for level 4 centers. They have such high turnover, and it's often the trauma program manager who's often the registrar. I agree that they need the education, absolutely, and we need the consistent data, but it is going to be a struggle as we move forward for access in the hospital being able to afford the classes, and so there's going to be an opportunity to have that baseline education for them, because they're not ready to have the certification and all that right off.
I think we need to set the expectation and the standard and ask them to strive to achieve it.
I just want to remind everybody, this committee already made that recommendation. It's in the proposed rules. So we then would have to be challenged how to help these people. However, we do that. It's our job to help with that. But the real question on the table is whether or not we want to write the college with a position statement or a formal letter saying that we disagree with your decision. This is what we are proposing. So Ronnie's already said yes. So is there a motion to do such?
I make a motion.
Ruben makes them.
Yeah.
Who made the second? Dr. Smith? All those in favor? Wait, any other discussion? Anybody in the audience have any comments? Okay, then all those in favor, please say aye. Aye. Anyone opposed, please say aye. Okay, so we move forward. So I'm going to switch chairs so I can just show you some of the data from our state registry. So I just want to show you, this is the data that we asked Tammy's group to pull out for us. And so we did two things. Tammy pulled data out for us, and her staff created some PowerPoints. And at the same time, we were interested in looking at the National Trauma Data Bank comparison to what we're doing. And so Garrett and I put some stuff together. So you're going to see both presentations here. You'll see some number differences, and the number differences is that Tammy's group pulled out the TBI patients and some of the transfers, and then the data that you can tell if they came from our data, meaning Garrett and I, because they have a red background. The ones that came straight from the state have a white background. So again, I believe in having a data-driven system, so if people want to know where we're at, what do we need to work on, it should be based off of data. So again, this is just the talking points, and so the goal of this data is, again, to look at the medical community and the public to foster decision-making based on actual outcomes of the current injuries and injury outcomes, the cost of care, and hopefully identify opportunities. So the data that you're looking at is 2011 data that we submitted to the Texas Trauma Registry. And so this is a breakdown of the hospitals, and again, you notice it's a white background. It came from Tammy's data. So there were 15 level 1s, 10 level 2s, 48 level 3s, and 184 level 4s. And the interesting thing is you'll see there's 66 non-designated facilities. So I asked Tammy, I said, are these hospitals going for designation, or, are some of them just being compliant? Some of them are being compliant to the rules, and many of them are going for the designation process. And so the trauma incidents by trauma center, so you can see the breakdown, the level 1s, level 2, level 3s. And so again, what we're going to do is put this into a PDF and post it on the TTAF website as well as the DISH website, so you'll have access to it. And so this just gives a breakdown, so you can see 32% of the admissions or the submissions came from the level 1, the level 2, 11%, the level 3, 26%, and level 4 is 20%, and again, the non-designated 11% of the data. And so if you look at the total charges, most of us were here Tuesday talking to the people at the Capitol. This is some of the data that we talked about. There's over $4 billion of uncompensated trauma, or $4 billion of care being provided within the state of Texas for trauma patients. So the average charge is about $45,000. The minimum charge is about $50,000. And so the maximum, again, was like $9 million. So again, injury by primary payment source, the Medicare, Medicaid, and you can see Medicare patients are the lead here, and then next to the self-pay. Now that's a huge issue, because when you think about uncompensated care, what we were doing at the Capitol, this is why we were there. We're talking about people who are injured who can't pay their bill, but we are obligated to take care of them, and that's what we all want to do. We don't want to worry about the funding. And then the conditions at discharge, you can see, again, this is from Tammy's data. She has 93,000. The data that we looked at that were included, everybody that was submitted, was 117,000. So non-fatal is over 90,000. Fatal is about 3,267 patients. Those are invalid codes, 43, so we don't know if they lived or died. And so this begins to look at some of the data by age breakdown. And if you look to the left and you compare it to the far right, this is what we read about in the textbooks. We can all quote the numbers that, the geriatric trauma patient population makes up only about 11% of the overall injuries, but they are the highest bill consumers, as well as the ones who die the most frequently. So you can see that their mortality rate is higher than the other patient population. So you can see from this slide there are 117,000 injuries, and then our mortality rate for the state of Texas is 2.7. So in this group of data, there were 3,267 deaths. So if you look at injury by age group, you can see from the infant to the over 85. Now you will notice, if you remember, we showed the same slide last year, and there were a lot of issues with age. So it looks like people learned that lesson and went back and corrected some of their age issues. So the Texas trauma incidents by age, again, this is just the whole entire patient population. So you can see, we're going to show you that this looks very familiar to what's also in the National Trauma Data Bank. And so this just shows the female versus the male. So you'll notice that men die early, right? So you can see we're injured more frequently only because we're still alive, guys. So this is the National Trauma Data Bank. So you can see the slide to your left, or the graph to your left, is the 2012 Texas Annual Report. That's what we're calling this. And so if you'll look at the incidence of the geriatrics, we're a little higher than the National Trauma Data Bank. But you can see if you graph it out, it looks very close, right? And so the injury severity score by age, again, you can see the ISS is in blue for 1 to 8. Now this is a big issue, because I believe that almost every hospital in America should be able to take care of a patient that has an ISS score 8 or below, if you really think about it. And so when you get into the ISS of 9, you start getting your femur fractures, your head injuries that can be very different. And so again, age makes a difference. Their comorbidities and the medications that they're on can make a huge difference. So the 9 to 15 is in the red. The ISS of 16 to 24 is in the green, and then the ISS of 25 and higher is in the purple, so you can see that. And then the missing data is the light blue. Now that's a little concerning that we don't have the ISS scores on these patients. Now, this is important to all of us. You know, yesterday, Tuesday at the Capitol, a lot of people were saying that the 3588 has not addressed alcohol the way we thought it would. It was never intended to address alcohol. But if you look, these are the questions that we ask in the registry, that the alcohol was confirmed by a test, it's beyond the legal limit, and then yes, it was confirmed by test, no, it was not confirmed by test, and not tested. So again, in the level 1 and the level 2 trauma centers, we're required to participate and have an expert program. So if you're not familiar with that, that is a very brief intervention for alcohol-related injuries. So you talk to the patient, identify if there was alcohol involved, and then you have to provide an intervention program. So the level 1s and the level 2s are pretty much required to draw blood alcohols on every patient. So you can see the no makes me wonder if this is coming from the level 3s and the level 4s. If you look at the median length of stay by ISS, again, the 1 to 8, 2 days, ISS of 9 to 15, 4 days, 16 to 24 is 5, and then greater than 25 is 6 days. Now, there's a lot of outliers. There's 2 outliers at Parkland. One of them is still in the house, and we're, I think, on day 284. So, again, there are some discrepancies if you look at pulling out specific cases, but overall, that's the median length of stay. And the Texas case fatalities by age, notice the 85-year-olds, we all read about this in the textbooks. This confirms that the mortality rate for those patients goes up to almost 4. And then the Texas trauma incidence by age and trauma center level, you can see the breakdown again by age. It's just a different way to look at it with the entire data set. Now, this is the data from the level 1 trauma center. So we broke it down by the patients that were going to the level 1, level 2, and level 3, and level 4 facility. So you'll notice that there were almost 37,490 patients that were managed in the level 1 trauma center. There were 1,515 deaths with a 4% mortality rate. In the level 2 facility, you'll see that the total incidents evaluated and managed, admitted, again, coming out of their trauma registry, there was 13,034. There were 428 deaths, and you can see the mortality rate is 3.2%. The level 3 trauma facilities, they admitted and managed 29,939 patients with 2.5 mortality rate. And then the level 4 facilities, 23,737 patients managed in those facilities. And then again, there were 367 deaths with a 1.5% mortality rate. And then these are the non-designated hospitals. So my question is, there were 184 people that died in those hospitals. So it makes me wonder, again, we need more information. Are these hospitals actually in pursuit, or are these hospitals just participating in the system? And many of the field triage criteria will say if the patient is in CPR, transport to the nearest facility. So it may be those type of patients as well. So this compares the National Trauma Data Bank. So if you look at the red group, the circle on the bottom, our overall mortality rate in the state of Texas is 2.7, almost 2.8%. And the overall by the National Trauma Data Bank is 3.8, which means that our mortality rate is at least 1% lower than the national mortality rate. So you guys need to turn around and look at the person to your left and to your right and tell them that they're doing a good job, because the Texas trauma system is working. So this is the mechanism of injury. We want to talk about injury prevention, but we need to know, okay, well, how are we being injured? So this is the categories that come straight from the CDC. This is broken down by Tammy's group. And then the top 5 mechanisms, again, you can see fall, the motor vehicle traffic, struck by a car, cut, pierce, and then transport other. So again, you can see this is the breakdown by the Tammy's group from the registry. Falls, 43,000. Motor vehicle crashes, 19,000. Struck by or against, 6,000, almost 7,000. Other types of transportation, 4,131, and then the cut and pierce is 3,894. So you can see the incidence there. And then the top causes by E-codes are falls, unspecified falls, motor vehicle crash, and then finally falls again. So obviously those are the 2 top contenders. These are the leading fatal injuries: motor vehicle crashes, falls, firearm, and then struck against again, and then other. So again, these are the 4 leading top E-codes: falls, unspecified falls, motor vehicle collision with a pedestrian, and then motor pedestrian. So this is the breakdown if you look at all of the data. I think it's interesting that falls make up 46% of all of the registry admissions. And then you can see motor vehicle crashes 22%. So I know you guys hear a lot about firearms, and we're going to talk a little bit about gun control at the end of this meeting. And you can see that's only 2% of the patients in the trauma registry. So trauma incidents by selected mechanism, and you can see again 46% falls, 22% motor vehicle crash, and so on. So again, this is the CDC group, so it compares how the CDC breaks it down in comparison to our state trauma data bank. And then we broke it down by the level 1, so you can see from the falls, 31% in the level 1s, 30% motor vehicle crash, and then you can see this is the level 2 data. The falls, 47%, motor vehicle crash, 23%. And then the level 3 facilities, 48% falls, motor vehicle crashes, 24%. And the level 4s, again, 59% falls, 11% from the motor vehicle crash. So the incidents by injury severity for all the patients, again, you can see the breakdown. This is the level 1 trauma centers by injury severity. The level 2s, you can see some difference, and then the level 3s and the level 4s. So that's just a quick synopsis of the data, so you can see, I guess what I would like to point out is the registry is working. There's certainly challenges. We need to continue to improve what we're putting into the registry to improve what we can get out of the registry. So when you request data out of the registry, you need to be very specific how you want it. There are some challenges, there's no question, so I just would like to ask the committee if they have any questions about the data that you just saw. Comments? No? Anybody from the audience? It's a lot of data to absorb in 10 minutes, right? Okay. So the item on the agenda that talks about the system survey, a lot of people are asking what type of survey is this? So if you all remember, we had a ACS consultation in May, I think, of 2010. Y'all remember that? Or is it 2011?
2010.
So there's a model trauma system plan that was, it was a revised from a 1992. So this is a 2006 model trauma system plan, and we took that 140-something page document and turned it into a criteria checklist. So that survey that's out there, and so that survey will be actually, in 2 weeks, you're going to be asked to start answering the survey, is asking you specifically questions that follows this criteria document. So we're going to ask all EMS agencies, all RAC participants, as well as all hospitals to participate in the survey so we can get a feel for where we're at in the state of Texas, and again, compare it to our data, what we need to work on and to improve. Any questions on that? Okay, Jane, you can change this. So we created a trauma registry work group. I would like to propose that we create another work group called the Trauma Best Practice Work Group. This work group is specifically targeting the medical directors to look at opportunities to share best practice. There's an item on the agenda that talks about geriatric trauma. We don't have that finalized at this particular time. There's still a lot of issues with geriatrics. Today in this room, before the meeting started, no less than 10 people asked me, what type of geriatric patients do you put in your trauma registry? So there's a lot of opportunities to create a consensus in our populations. The other goal is to communicate activities of GTAC, the rule changes, and so I would like to propose that we start this work group and ask Brian Eastridge, who was on this committee, to actually chair this work group. I talked to Brian and he's very interested. He knows that it has to be approved by this committee.
Second.
Thoughts? So we have a motion by Dr. Smith A second by Dr. Stewart. Any questions, comments from the members? Anybody in the audience have any questions or comments? That meeting will start in May. So again, let me point out the advantage of having it as a work group. As a work group, you can have conference calls, you can have communication by webinars, you can have a face-to-face meeting, and you can call it at any time. You don't have to follow the open rules recommendations. And so that's one of the advantages we see with the registry as well as this work group. Any comments? Okay, then we need to make, all those in favor of this, please say aye.
Aye.
Anyone opposed, please say aye. Okay, thank you very much. Motion passes. Number 5, we're going to turf to the next meeting, as well as number 6. There's still data that we're trying to gather on that. Can you switch slides, Jane? So feedback and communication. So everybody that serves on this committee is expected to, number 1, represent the injured patient and try to improve the care to that patient. But there are also other individuals, and I know that their names are not spelled because I had to correct some of the names earlier. But if you see your name by a specific item, that means that the expectation is that you are expected to work with that group and get information back to them. Now, we did learn today, I didn't realize that some of these hospitals that we chose people because there were 3s or 4s are moving, wanting to upgrade. So that's good. We want to support them in that process, but we're still going to ask them to help work with some of the other groups as well. Any questions on that? So find your person, you're in the audience, find the person that's going to represent you and make sure you contact and work with them before the next meeting. Okay, Jane. So TTAF, is Dinah in the room? So I just would like to thank Dinah. I think she and Brenda and Steve need a round of applause. I don't know. If you were a part of Trauma System Day at the Capitol, please stand up. It's EMS Trauma System Day. If you attended or spoke to somebody, please stand up. Because that was a direct result of Ms. Welch.
Thank you, Jory. The EMS and Trauma Day at the Capitol, it was our 3rd time to do it, and I think it was very successful. I think its greatest success is the time that each one of you all take to go visit with legislators. And I know we had, I had a small group of people, and we had some very fruitful visits. And the focus, obviously, is trauma funding, EMS and trauma funding. And one of the things that we really tried to focus on was not just the hospital's portion of the trauma funding, but also highlighting the RACs and EMS as well. The box that they put us in 2 years ago of reducing our funding to $59 million, I don't want anybody but the Capitol to get the idea that that $59 million fits for us. With over $200 million in uncompensated trauma care costs, y'all know the story. The need is great, and that's just what the hospital costs. And so we'll continue to fight that fight. I think some of you all also experience the frustration that we deal with all the time, but I say it's the 99% rule. We are the 1% that actually understands the different levels of trauma centers. We understand what a RAC is. We understand what EMS is. We understand the system and how everything coordinates together. Most legislators, most people that walk into y'all's facilities have no idea or get rolled into your facility. And they are just, at the end of the day, they're very thankful that there are those of us that do take the time to learn and figure out how to create a system that works. So you all are to be applauded for the time and the effort that you all continue to put into making this system so successful. As I also said up at the Capitol, nobody's against trauma funding. Nobody's against emergency healthcare funding. It's just how you prioritize it. They may be against the funding mechanisms. They may be against the driver responsibility program, but nobody's out to do away with the trauma center. Nobody's out to do away with EMS. Everybody wants that, and it's just trying to figure out how do you prioritize that with public ed and roads and bridges and prisons and everything else that they have to focus in on. So we'll continue to chip away, but I know many of you all had some really good visits. I appreciate that. I appreciate the feedback too, because it does help as I go make visits in the next couple weeks to know who's thinking what, who's planning on filing what. But and I see Marvin's name up there. I'll just make a plug. Marvin did an exceptional job of really rallying the TTCF troops and encouraging the visits and getting those visits coordinated, and I really, really appreciate his time. The little stickers that everybody wore, he printed those off on his own little computer. So thank you to Marvin. I appreciate his passion and just his excitement for getting everybody coordinated on that. So I don't know if that's what I was supposed to say, but and I'm happy to answer any questions or talk about legislation later maybe.
Anybody have any questions for Dinah? Y'all are very quiet today. I am not used to quietness.
Thank you for the good
Thank you, Dinah.
Thank y'all.
Thank you. Thank you.
Oh, and I said it last night at EMS. I think the governor will always remember our group. As one of our members of our group managed to slap the governor, and but I said at least she didn't throw a shoe at him or something, because then that would really be an insult. But it was fun, and I think he will always remember us. Even if he gets just level 1 trauma centers, at least he knows something about trauma, and he is supportive of driver responsibility program and its funding source. So that's the takeaway, and we can now put that out there on the wire. So thank y'all very much again for being there.
Anybody from the audience have a question for Dinah? Thank you, Dinah. You want to hit the next slide? So now we're going to get into some of the controversial issues. So at the last meeting, how many of you remember the November GTAC meeting? How late did it go? Too late, right? So why did it go that late? What was the discussion? This is a test. Dr. Stewart, can you just remind us? Since you're our GTAC liaison?
You didn't prompt me ahead of time, so. I believe it was over the schedule and how the meeting could be arranged and how the stakeholders felt and what the issues were. Am I correct?
You're correct.
Okay, good.
So there's two
Remember, I've had a stroke.
There are two controversial things we're going to talk about today. This is one of them. So the issue is, how many of you have trouble traveling and staying down here from Tuesday to Friday? Raise your hands. How many of you find it an issue to be down here for 2 days? How many of you want to stay down here a week? No, just kidding. I'm just kidding. So the recommendation, or what GTAC would like to do, is create a format that they could have all of the meetings in 2 days, but provide enough opportunity for you to have good discussion, good outcomes, to really do what you need to do. So the first question, we're going to skip the 2-day venue, but we are going to talk about the time frame. So we were asked as the chairs to go back to our committees and define whether or not our committees think that we can meet in an hour. That means start the discussion in an hour, or whether or not we need 90 minutes for each meeting. Yes, Dr. Stewart.
Can I add just one more thing in that I think in that November meeting, I think the GTAC recognized that there were probably some communications issues and concerns, and so to address those, the recommendation was to try to make an executive committee that involved the committee chairs, and that's happened, moved forward as one of the main initiatives of that too. I just want to point that out. That's in context of this discussion.
So that executive committee meeting that he's talking about was a conference call this time, and it started out with whether or not we can go to 2 days. But again, the goal is to not compromise the quality of the meetings and what we're doing. So with that said, each chair was asked to talk to their committee's members and to their stakeholders and ask the question of if we feel like this committee, the Trauma Systems Committee, can meet in 60 minutes or do we always need 90 minutes? I'm just going to go on record saying I want 2 hours. So for me, a compromise is 90 minutes. Is there anybody that disagrees with that? Okay. So the next question we want to ask you is how late can we work? So let's just throw out there that we're going to have meetings. Let's just do something different on Tuesday and Wednesday. So you're going to come in on Tuesday and we're going to be done on a Wednesday. So we've had the GTAC executive group, all of the meetings, and then GTAC final meeting, and you're going home in 2 days. So the question is, how late are you willing to stay and work? How many of you say you're not going to work past 5 o'clock?
And does it make a difference on which day?
Yeah, we're trying to do the length of time first.
Oh, okay. That's what I meant to say.
How many of you are willing to work till 7 o'clock at night? Raise your hand. Not all of you. How many of you would go to 9 o'clock? A few. How many of you are saying 6 o'clock, I'm done, I can't take any more, my rear end can't take any more, my head can't take any more? So it looks like 7 o'clock is reasonable. Well, we're getting to that.
When you start.
She's getting to that.
So the next question is, you're willing to stay to 7 o'clock at night, so let's talk about how early you're willing to get up the next morning. So how many of you are willing to start a meeting at 7:30 in the morning? Raise your hands. How about 8 o'clock? Some of you are not raising your hands for anything. 8, 9, 8:30. More for 8:30. I have to make a recommendation to GTAC, so I really need you to get engaged here, because if not, you're going to have to deal with it. So 7:30, raise your hands. Good. 8 o'clock, raise your hands. It's about the same. 8:30. 1.
2. I would prefer 8:30.
9 o'clock. So it looks like 7:30, 8:30s have it. I mean, 7:30, 8 o'clocks have it. So how about 8 o'clock will be our recommendation? Okay? Now, based on that, the next thing we have to define is which day, first day, second day, because it could be Tuesday, Wednesday, Thursday, Thursday, and Friday. Which day works best for y'all? First day or second day?
What are you asking?
For the Trauma Systems Committee.
Oh.
Are we still going to do TTCF and PCAP on Tuesday?
Well, we're not going to start this till next year. It's my understanding.
What I'm saying is, if you're going to say first or second day, we got to know, I mean, if you're going to be here for 2 days, and I want to be here for TTCF also.
We're talking about TTCF is separate from those 2 days. So I'm asking you the first day at GTAC, right, the first day at GTAC or the second day at GTAC? Knowing that TTAP is going to, TTCF is probably going to be the day before the first day at GTAC. First day. Raise your hands. This is important. You got to raise your hands.
What are we raising our hand for?
First day.
You want the Trauma Systems Committee. You want the Trauma Systems Committee on the first day of GTAC. Raise your hands.
What do you want?
Whatever y'all want.
Oh, come on.
She wants first.
First? Okay, I'm for that.
Okay, everybody put your hands down.
That makes me
Everybody
sad.
wants the Trauma Systems Committee on the second day of GTAC. Raise your hands. Okay, so first day has it. at 8 o'clock in the morning, and you'll work till 10 o'clock at night. Just
7,
kidding.
you said.
I just want to see if you're paying attention. Okay, got that solved. Got it? Next slide.
What days of the week?
Oh, yeah.
I mean, I don't know, you mentioned days of the week. I just thought you might want to ask.
Keeps me in line. So, how many of you want to move away from the Thursday, Friday GTAC schedule? The reason we're asking is because, let's say we have a meeting that goes until 7:30 at night on Friday. Many people are saying it's difficult for them to get out. The hotel costs go up. So, how many of you would like to see the 2 days of GTAC move away from Thursday and Friday? Raise your hands. A lot of people. So, now that we've decided that, which days of the week? Wednesday, Thursday. Raise your hand if you prefer the Wednesday, Thursday. A lot. Raise your hands if you prefer the Tuesday, Wednesday. How many want to do Monday and Friday?
Can I ask why? Well, I want to know why a difference, because I'd like to hear people say why they prefer Tuesday, Wednesday over Wednesday, Thursday. I'm serious. I don't know what the difference is. They're both in the middle of the week. Personal. I mean, I would guess there's personal, but it seemed like everyone grouped up there in the Wednesday, Thursday. If it was just personal, I would expect it to be a 50-50 split.
A lot of the stakeholders that are represented here are the trauma nurses, and historically, TTCF has met on the Tuesday. So it makes sense for that group of stakeholders, which is a large group, to come in on Tuesday, have the TTCF meeting, and stay over to the Wednesday to come to these meetings.
So then Tuesday, TTCF, what's TTCF?
Hit him, Kathy.
That is good. She was going to tell me too. So come in, so TTCF on Tuesday, then Wednesday, Thursday.
Yes.
Okay, yeah, I'm for that.
That's what I thought you said.
And TTAF, yeah. And TTAF is Tuesday night.
Right.
Correct.
It currently is. Anybody else want to comment on this? Victor Stewart has the opportunity to report this out at GTAC tomorrow.
Well, you have the opportunity. This is going to be really discussed tomorrow at lunch, correct? Isn't that the executive committee is going to meet tomorrow at lunch? So I'm counting on you to get all this really straight.
Okay, got it. Got it.
Because I'm going to blame you if it's not right.
Trauma medical director.
Yep,
Okay.
that's right.
Let's move into the open discussion. Now I want to bring up the issue of controversy. Well, just put your hats on because you'll agree with me here in a second. So, how many of you have heard anything about gun control?
Hey, can I ask one more thing about this? Hold on, seriously, one more thing about this. So there's also because you didn't bring it up, the issue of a TTAF meeting, GTAC meeting, council meeting to start the 2 days. In other words, a GTAC council meeting to start and then to end, if I understand that correctly.
I didn't really bring it up because I think most of the people that are here would probably attend that anyway. But the big issue is that that's really to set the stage for what we're going to do for those 2 days for the committee chairs. That was my understanding of that. So what Ronnie's talking about is, let's say that we go with the Wednesday, Thursday. So on Wednesday morning at 7:30 or 8 o'clock, the GTAC Executive Committee, which is Vance Riley, Ronnie Stewart, and all the committee chairs meet to talk about their agendas, and not to go over their agendas, but to focus on what they need to accomplish in their meetings. Any issues, controversy, anything new they want to bring up. Right? So you would have the opportunity to participate or to sit in on that. And then we'll go through our meeting activities and then summarize it at the end, just like we currently do with a formal GTAC meeting. Is that correct?
Do you think that's a good idea or neutral or bad?
I like the idea because it allows me to hear what goes on in other committees and what their priorities are to make sure we are interlinking and working and collaborating with them. Thoughts from the group, committee members?
Well, the other part of that, having the initial meeting, is so that the department gives whatever reports we give or whatever information we need to give all the committees, so we don't have to have the same report at each committee meeting. They all get the same information.
That's correct. Anything? So y'all think that's a good idea? Shake your hands, raise your hand. Okay. Okay, now let's go back to the controversial issue. So, is there anybody in the room that hasn't heard somebody talk about gun control in the last 2 months? Well, I just want to make it perfectly clear, I'm not proposing that we do gun control. But I think for us to not talk about some of the issues with guns is to bury our heads in the sand. So, I'm on another group, and they were also an organization very similar to this, asking about what do we do, because nobody wants to make the stand of ban this or ban that. And so they are a group of healthcare providers, trauma physicians, trauma nurses, and so their decision was to work on education of what guns actually do to human beings and the types of bullets and the types of guns. For example, you know, if you look at the 50 mag gun, those things can cut people in half, right? Whereas the 22 caliber can cause an injury, may not kill you, but in the right place it could kill you. But to provide education. So my question to this committee, to the group, is do we want to do something with gun control? We could move it to that new group that Brian Eastridge is going to chair. But I think for us to not talk about it is a mistake. So I just want to open it up, and again, I'm not going to take any stand on this. The thing that I'm worried about is if we say we're going to ban guns, 50% of you are going to walk out of the room. If we say we're not going to take this stand, another 50% of you might go out of the room. So we need to say something. We need to do something about this, but any thoughts? We're not going to solve it today. I'm just bringing it up for today.
Jory, I have a question on the stats that you presented. When you look at all the trauma registry, gunshots were 2%, the lowest, correct? It's just a yes or no question.
Yes, it is.
Okay. So with that said, I favor education, but on top of that, for sure, without a question. But with that said, I think that not only education, but a strong wording from our group. And when you go buy a gun, like for instance, do you consider a car a lethal weapon?
In the wrong hands, in the right driver? Yeah.
But what does it take you to get what gives you the privilege of driving a car? You have to get a license, you have to take a course and all this stuff, right? Same thing with guns, so why can't we recommend, I'm not saying banning, because I would be the last one to do that as well, but something in that regard, not only education, but the process of obtaining one.
Right. I think some of the other organizations are going with, you know, if you think about the car crash, you know, there are many things that we've done to address or to decrease the injury severity in a car crash. You know, and my issue is this is controversial. I'm the one that brought up on this conference call that only 2% of the patients that come to our trauma center come because they were shot. Mm-hmm. The issue is there's enough evidence out there that they do kill people. And many of those patients don't arrive in the trauma center. So I think, you know, we can say we're not going to do anything. I'm fine with that. But I don't feel like the chair we can walk out of this room with at least some discussion of it. Dr. Stewart.
So I'll just say, I think maybe we should give disclosures on all this stuff. So I'm a gun owner. I own guns. I don't really own a handgun. I've got shotguns. I don't use guns very often, but and I support the Second Amendment freedoms that people express. So I support that. The thing, what I would say is if we're going to do anything, which I'm not certain I'm in favor of, but if we're going to do anything, I would not be in favor of doing anything unless it was a nuanced, actually discussed the issue fully and had recommendations. If the goal is to decrease gun-related injuries, you know, I'm all for that. I'll just point out some things that are obvious to me. In the past 3 months or 2 months, whatever that time interval is, we've seen all this discussion about gun control has probably led to the greatest single 3-month period of purchasing of assault rifles and weapons and handguns at any time in the past 30 years. And so if the goal is to reduce that to some degree, well, that has not been achieved. And it will not be achieved. And I think we have to recognize, and why, if I would favor us doing something, if I would favor us, I would say a reason to do it is we're in Texas. Okay, so we're in Texas. And if we could come up with something that people could agree upon, then I think that would be worthwhile. I think that's going to take a lot of discussion and a lot of tolerance of different points of view from people who agree and disagree. So, and I think we have to recognize that there are differences in the way guns are viewed in the West, rural West, Southwest, than how they're viewed in the Northeast, and that, right or wrong, I think it's wrong personally, I'll just say. I don't think it's an accurate assessment. It's a holdover. But I think guns are viewed as a symbol of freedom in the Texas, the Intermountain West. I personally think they're viewed that way. In the Northeast, people view it the opposite. I'm stating what I think whenever I talk to colleagues everywhere. So the other thing that I think that's maybe not obvious, but it's obvious to me, is the pro-gun people are more committed, more fervent, hold it nearer and dearer to the hearts than the no-gun side. I think they are committed, and it's an issue of freedom to them. So if we could actually meet to talk, if we could actually have some discussion and dialogue that led to, maybe some consensus, I would be in favor of it. And I've already given a speech on it, so that's what I've just done. So I apologize. But the other thing that I will say for the gun people in the audience, it's me. I personally think this issue is like many challenging issues that we're struggling with, and we're really big about freedom, but we're not so much about responsibility. I personally think that's an American way. I could go through all of our major issues, and so if I had my way, I would model the gun issue on the Texas trauma system, i.e., I would model it in the sense that if you think about what the Texas trauma system does, essentially we're regulating the trauma system. We are. We're imposing rules. You've talked about cost. We're imposing a bunch of rules that basically make us do certain things, but that is being driven by the stakeholders themselves the people who are caring for the patient, the people who are doing that are the ones pressing for it. Think about how we might view it differently if there was some other stakeholder group outside of this room who was insisting that you need to do it this way, and there's 50 reasons, and by the way, if you don't do it this way, you're a stupid idiot. Well, we wouldn't be much in favor of it. But actually, the people who are the beauty of this system, in a way, is the people who we have the freedom to practice the way we want, but we ourselves have basically pushed for what we think, I mean, I'm biased, what we think would be reasonable rules and regulations for that.
Hi, I'm Shelley Stevenson. I'm with the Injury Prevention Center of Greater Dallas and also a member of the Injury Prevention Cmte Committee. And first, I just want to say, Jory, kudos to you for even bringing it up. I think for a long time we've just steered away from it because it's been too controversial. So I think I want to applaud you for even bringing it up. A couple of things. I think that the time is probably, this is probably the best time to even have this discussion because of recent events in the last 3 months or so. I think there's a lot of talk about it, and so it would probably behoove us all to have the discussion. I think we have to be careful in terms of the terminology that we use, and Dr. Stewart kind of alluded to this. I think when we hear control, you're thinking of banning guns and things like that, and in the spirit of full disclosure, I don't own a gun. But I have a lot of family members who are hunters and who do. So I think that we have to come together in a sensible way to have the conversation and try and steer away from some of those really controversial terms like control and ban and things like that. The only thing that I would caution us about, and the rules and it may have changed, but up until probably just recently, and again, I don't know if the rules have changed or not, I think we have to be careful because agencies and organizations that have received CDC funding have been prohibited from even talking about it. So I don't know if those rules are changed or not, and I just want to be careful about, because I'm sure that DSHS does receive some CDC funds. So even the injury control research centers that have received CDC funds in the past could not have not been able to address even doing an interview on guns or anything like that. So we just need to check on that and see if those rules have changed.
I guess the other issue that I brought it up because I think it is controversial, and I don't think we should bury our heads. I think that most of us in this room are pretty straightforward. I don't want to change any laws regarding guns. That's my personal bias. But my efforts and my attention to injury prevention focus on drinking and driving. We lose more Texans from drinking and driving crashes every year. We lost more Texans than we lost in the war. So we could really compare that, but I feel obligated as the chair to at least bring it up, to either start the discussion and move it where it needs to go, or to hear that's not an issue that we want to address at this particular time. And I'm happy with either one of those.
Jory, I did want to bring up, I don't know how, but in my mind, when we see the mass fatalities that happen, the issue at hand with those seems to be mental illness. And the identification of mental illness and the lack of support for those individuals that are even identified or not identified, access to the system. I think there is an opportunity maybe for, it hasn't happened yet necessarily in our state, but it could, and I think a lot of us live in fear of that every day. And so I think there is opportunity there from an injury prevention standpoint, an education standpoint, and then a partnership maybe with, how do we identify mental illness and use that as an injury prevention platform for trauma? I don't have the answer to that, but that's just my thoughts on, it's not whether or not you combine the lack of identification with the access problem that anybody can get a gun.
That's where the issue is.
I agree with Lori. It seems like with the latest guy at Sandy Hook Elementary, that when you read things on him, even in school, they knew something was different. Would it behoove us to start working with schools, recognition of potential issues, potential people that might have those issues? I don't know what education on the difference between 22 and a 357 mag is going to do. If you're going to,
If they really want to kill somebody.
those people that are really going to do that already know the difference between those probably far better than I do. So let's put our money, I agree with you, Lori, let's put our money on that kind of a thing so that it can be prevented at that level. I agree.
I 100% agree that mental illness is very pertinent to this, and in the interest of full disclosure, I have several handguns. I'm a CHL carrier, and my husband is a firearms instructor, so I'm very used and familiar with guns, but we are responsible gun owners, and so if you're preaching to the choir, then you're going to have a lot of folks saying, of course, we advocate gun safety. I am the #1 advocate for gun safety. So what we are talking here is not only the mental illness aspect, but the criminal element. And so these are very difficult issues in our society, per se. So it's a difficult injury prevention project because you're having to focus on criminals who are going to illegally obtain weapons, whether there's regulation or not, and are going to use them indiscriminately and however they want to. And then folks who have a history of mental illness that are unable to access mental health care services. So that's a difficult target audience when you look at gun safety programs. I hate to call it gun control, gun safety awareness.
I do too.
Hello, Brian Norris from the San Antonio Firefighters Association. I think it's interesting that this topic has come up here. In this industry, being whether you're an EMS guy and fire guy like me or working at a trauma center or whatever, we're both reactionary and proactionary when it comes to this issue. When a gunshot rolls through the door or it comes to my scene, we're reactionary. That's what we do. And so education as far as gunshot wounds, things like that, I would caution, because sometimes education can be used against you. And so I really don't want guys knowing that if they hit me with a 50 cal that it's going to cut me in half. That's just a personal preference. Well, it may not, because I'm kind of a big guy. Sorry, it may take 2 shots. But on the other end of that is I think we can be proactive in understanding on how to get people not to use guns against us. One of the biggest fears from the EMS side that I have is going and banging on the wrong door in the middle of the night, or trying to evacuate somebody because of a fire and hearing the rack of a shotgun on the other side. And so I think that there's tactics and training that can be taught to responders. For hospital people, how many times have you had a guy that walks in with a gun that wants to finish the job that he started in the first place? Taking those types of topics from a safety standpoint for us and learning how to prevent injuries to us, I think is where your education needs to be focused, not on teaching people the different types of ammunition, all this other stuff. You know, if you hit this guy with an AK-47, it's going to splatter real neat and stuff like that. But also, like this lady was saying here, I'm sorry, I don't know your name, the mental illness side, the gaming side, the TV side, there's a lot of different issues that are going to come to play with this. And so I would just caution what type of education you're going to put out if you do send it.
So I'll just tell you my comment on that phone conversation where they were talking about the education piece is that as a trauma center, we are obligated to use the data of the patients that we take care of, right, to define our injury prevention and our activities. So if we stay true to that, our activities would really focus on motor vehicle traffic collisions with alcohol. There's no way you cannot look at the information, and then the geriatric falls. So that's sort of how I would end the conversation in a very difficult situation. So maybe that's the way to end this discussion too. But I feel obligated as the chair of this group to at least bring it up and provide the opportunity for that discussion. So any other issues anybody wants to bring up?
So since you brought it up, and I do applaud you. I think that's just very good. I mean, I'll just say, we tried, it's been a decade ago, but we actually surveyed Texans. We did random digital survey. I may have shown some that data to some of you on Texans' issues about injury and injury prevention, and we included a gun component to it. And Texans, this is not in an inflammatory phase where everyone's all talking about some event, but I mean, 3/4 of Texans favored treating gun. We didn't phrase it just like this, but I'm going to interject what our intent was. That 3/4 of Texan gun owners favored making guns that could only be fired by their owner, like a key, for example. They'd want a key, but like if you had an entry, I don't think anyone would be in favor of having cars that had no ignition lock that anyone could just get in and drive. And so 3/4 of Texan gun owners favored that, and a slight majority favored reasonable regulation, unquote, that if it would make things safer with respect to a Texan. So it's not, and really we tried. We got the head of the Texas Rifle Association, and I can't actually remember the organization now, whatever would be the polar opposite of them, to talk about this, and it was not, that didn't work out that well. I'll just say there wasn't much of a discussion.
Any other comments? Anything else?
Sure. I really think that somebody brought up the mental health aspect. One of the things that's not in our registry data, I don't think, is the status of the patients that we're taking care of. And anecdotally, it seems like we have a fairly not high percentage of very seriously hurt people whose problems started with mental health. And I think that's the unignored elephant in the room. We disbanded mental health in this country starting in the 60s. We emptied out the asylums and turned them loose, and now those same people are largely living under bridges. I think it's a huge thing that needs to be talked a lot about.
And just one other comment with that, because I was going to hit on kind of the same thing. You know, when you're talking about prevention, I know we're not talking about child abuse here, but when you look at those instances, frequently mental health is an issue with the abusers that abuse children. And so that is another opportunity in addressing mental health issues and decreasing the childhood fatality due to abuse as well as injury.
Yeah. I wouldn't know where to start. Any other discussion from the committee?
I just wanted to make a quick comment. From my background in EMS, I feel like I know a little bit more about gunshot injuries, because I think you, on the EMS side of it, you learn a little more because you're the first responders to those patients. I think that when we're speaking of education, that we need to look at being an advocate for the education of our nurses in the trauma facilities as well, and teaching them more about the mechanism and what exactly the different types of guns do to our patients and how to care for those patients more appropriately.
My third comment, I would say, I think alcohol also is, in other words, thinking about what you guys are talking about, mental illness. I mean, really, if you look at the more mundane, if you look at the routine shootings that basically all of your trauma centers care for, I mean, it's an alcohol problem more than 50% of the time.
So one word before you leave. Please don't leave this room and say, that Jory Klein. I believe in bringing up controversial issues so that we can all be on the same page, or at least know that we addressed it. So we did address it. So are there any other issues that you guys want to bring up from the audience? Any other comments?
I just wanted to make one comment that the TTCF is actually working on providing education for our group on active shooter. And we have somebody hopefully scheduled in May to do that.
Good. I believe that's somebody. Any other comments? If not, thank you very much for your time and attention.
What's your email again? Stewart R? Stewart R, okay.